Talking about intertrochanteric fractures, it is important to describe the patient journey regarding standardized care pathway. Patient should be NPO, medicine co-management should be advised, multimodal analgesia, delirium prevention, medication reconciliation, anticoagulation reversal, preoperative thromboprophylaxis, diabetes mellitus, glucose control. A patient who is having intertrochanteric fractures, the patient should not go for further investigations regarding cardiac point of view unless there is left ventricular dysfunctions to a level that needs a transthoracic echocardiogram. These interventions should be advised unless the patient needs intervention for them. Otherwise, intertrochanteric fracture should be managed as soon as possible. NICE guidelines says to be operated within 36 hours, admitted within 4 hours. There is minimal role of non-operative management in intertrochanteric fractures. Intertrochanteric fractures, by the way, are extracapsular fractures and have good healing potential. A stable fracture will resist medial compressive forces once reduced. An unstable will collapse into varus or shaft will displace medially. The surgical goal will obtain neck shaft alignment and correct translation. Anatomical reduction of intermediate fragment is not necessary. Surgeon should focus on getting the patient to the OR as soon as possible. Ideal implant selection, obtain good reduction, obtain proper implant application. The close reduction technique is mostly successful. That is traction, internal rotation, and slide adduction. The reduction aids can be traction, crutch when using the fracture fragment to avoid posterior sag, ball spike pusher, bone hook, Hay-Groover's clamp, or collinear clamps, or other fracture reduction tool clamps. Implant of choice is dynamic hip screw, sliding hip screw, cephalomedullary nail, short versus long, and 95-degree blade plate, which is rarely used. Sliding hip screw and cephalomedullars allow for fixed angle controlled collapse, shortening at the fracture site. This is the principle of these implants. Sliding hip screw and cephalomedullary nails allow for fixed angle controlled collapse. Regarding the nail over the sliding hip screw, it is a load sharing device. It is an intramedullary buttress. Nail resists excessive fracture collapse and medialization. Nail more closely located to the axis of weight bearing than sliding hip screw. Regarding reverse obliquity type of fractures, a long cephalomedullary nail remains the preferred choice treatment in intertrochanteric fracture with reverse obliquity, demonstrating acceptable lesser complication rate, reoperation rate, and higher rate of healing. Regarding comparison of a best plate versus a nail, a trochanteric stabilization plate provides an intact lateral buttress for a sliding hip screw, thereby reducing the risk of medial migration of the shaft. So for unstable proximal femoral fractures, the recommendation is cephalomedullary nail or a sliding hip screw with a trochanteric stabilization plate. Indication for cephalomedullary nail in unstable fracture. The general consensus is number 1, a greater trochanter or lateral wall fracture. Number 2, significant posteromedial comminution. Number 3, reverse obliquity fracture. Number 4, subtrochanteric fractures. Otherwise, sliding hip screw works very well when treating stable intertrochanteric fractures. Regarding the long nail has advantage is protection of the entire femoral shaft, ideal with diaphyseal fracture extension. The disadvantage is its increased cost, longer OR time, increased blood loss, freehand distal locking, and possible mismatch to the bow of the femur. A short nail has advantage that is easier to use, target locking bolts through insertion of the jig, decrease operative time and blood loss, and are cheaper. The disadvantage is older designs had a high rate of periprosthetic femur shaft fractures, has large diameter, rigid stainless steel implants with large locking bolts at the distal tip of the nail, causing stress risers. Modern nails have low radius of curvature of 1 to 1.5 meters. Regarding short versus long intermedial nail in the treatment of pertrochanteric hip fractures, incidence of hip fracture and cost associated with each implant. Distal locking, in this article, distal locking seems to protect against femur fracture and may also affect refracture location when using long intermedial nail. Up to 8 or to 15% of the fractures can have a screw cut out while doing a short nail. The tip apex TAP should be always less than 25 millimeter in the subchondral bone. Regarding tip apex distance is an important concept in relation to screw cutout or in hip fractures fixation surgery. Surgeons should understand and apply the concept of TAD to improve outcome of their patients. The intermediate devices are susceptible to cutout if TAD is more than 25 millimeter. And surgeons should strive to have TAD of less than 25 millimeter when using intermediate devices, especially in the treatment of comminuted intertrochanteric fractures to help avoid screw cutout. Inferior placement of a lag screw on the anterior-posterior radiograph and central placement on the lateral radiograph is the recommended position of screw. A helical blade rationale is hypothesized to have better anchorage of compaction of the trabecular bone during blade plate insertion with rotational control. Does not require over drilling, which affect retained cancellous bone. Several biomechanical studies suggest that helical blades may have a higher cutout resistance, and they have opportunity to put cement through it also. Regarding a study where helical blade plates were compared to the sliding hip screw construct in elderly intertrochanteric fracture, the outcomes were similar with respect to cutout, and pre and post-operative complications were almost similar. The cement augmentation can be utilized via which helps in cement bone interdigitation, aimed to resist the screw cutout. Cement does not act as a void filler. Its augmentation away from the fracture, biomechanically superior. Safety studies needs to be performed. It is important to put a contrast dye before cement use to rule out intra-articular penetration.